With 13% of US adults having been prescribed a GLP-1 medication at least once, the increase in popularity shows that we need to be more aware of the risks that come with these medications. Stay tuned throughout this episode to see what risks these are.
Hi everyone and welcome back to the Chemist Couple podcast with me, Jess and Lee. So for those of you who are new here, we are both clinical pharmacists and we work in GP practices in the northwest of England. So let's get into this episode. We're going to be discussing GLP-1s and their risks. So like you just kindly introduced, it was a lovely introduction, they are increasing in popularity year on year. So you said there 13% of US adults have used at least once one of these medications. And then I read something where it was saying that by 2029, the market for these medications will be £126 billion. And I think in 2023, Ozempic was actually the medication that was worth the most to the market. So it shows that there's a lot of people who are using them now. Ozempic, as we know, is actually licensed for type 2 diabetes. So that doesn't necessarily mean that it was being used for weight loss. But it just shows how popular these groups of medications are, doesn't it?
It does.
We just wanted to discuss the risks associated with this because we have discussed GLP-1s quite a few times on the podcast, but like we've just said, they are growing in popularity and we are going to see more and more people being commenced on these medications or taking these medications. So I think it's just important for people listening to understand whether they are thinking about taking a medication such as these, or whether they know anybody, just to be aware that they are still a drug, they are a medication, and as with all medications, they do come with risks, side effects, and so there really needs to be a risk versus a benefit decision made between yourself and also the prescriber before you take them. So do you want to discuss then the first risk that we should discuss really, which is poor diets associated with people taking GLP-1s?
Yeah, so it might not come across as a risk because people are going to be eating less, which is the whole point of taking the medication. But when you take these medications, ideally, you should be adapting your diet to account for the reduction in energy that you are consuming. Mm-hmm. So if you are eating, let's say, a lot of fast foods, a lot of takeaways, etc., and then you're just eating less of that, yes, you will lose weight because you're consuming less energy, but then your health overall won't be really improving, will it?
No. And I think I've had a lot of patients recently coming to me or asking for a consultation with me whilst in clinical practice, asking to be commenced on these medications. Some patients are type 2 diabetic, while others are just purely using it for weight loss. But the common theme is that people want to lose weight on these medications. So whether they're asking for it for the treatment of their diabetes, the majority of patients have got a BMI of over 30, or all of them actually. And so, we know that the people are thinking these medications are sort of the golden bullet, if you would like, where it's going to basically they take them and then all of their issues are going to go away. And actually, yes, they are very effective and they will reduce your caloric intake, but unless you change your diet and your lifestyle to then be able to sort of maintain your goals going forward, we know that people who will just come off them will then fall back into old habits and it's not going to be sustainable. But in terms of poor diet then, and eating less for these patients, what are the risks? So, for instance, the first risk that comes to my mind is potentially the loss of muscle mass. So, as patients get older, they get what we call sarcopenia, which is a loss of muscle mass. Now, we know that patients taking these medications just simply because of the fact that they're losing quite a large amount of weight over a short period of time. GLP-1s, like with any diet that you would go on, do not distinguish between fat loss and muscle loss. And so if we do have a loss of muscle mass, we have a loss of metabolically active tissue. Also, it can weaken your bones. And so that becomes a problem. So are there any other ones that you can think of associated with poor diet?
Before I go into anything else, with that one, like you've just said, if you have a general reduction in energy content in a general diet, you will eventually lose some muscle mass. But the two most important stimuli for muscle growth is resistance training and protein intake. So if you're reducing your energy consumption, for example, and you're not balancing that by increasing your protein intake, and in these patient cohorts, they tend to not be performing resistance exercises. So then with them two being removed, you are going to reduce lean mass. But the other things that come to mind are vitamin deficiencies.
That would be one that I would think of as well.
Yeah, so as we have alluded to so many times, ultra-processed foods are, well, they're stripped of fibre. Yeah. So if you're just eating takeaways and you're just eating less takeaways and not supplementing that by increasing the amount of fibre and other diverse foods within your diet, you are going to suffer. So then it comes a thing of, do you supplement it with vitamins? And as we've discussed previously, they're not reliable because they're not regulated.
Yeah, that is true. And I do see a lot of patients online who are taking GLP-1 medications supplemented with vitamins. Now, you know, in that cohort of patients, it may be beneficial in the short period to at least get something in. But like we discussed in the supplement video, if you want to go back and have a look at that, it was really interesting to find out that they're not regulated. And so whatever it says on the label, it may not contain. And we know that due to the actual food matrix, it's better to get all of your vitamins from your food rather than getting it from a supplement,
of course,
which is what you've just said. So yeah, that would be another thing. I'm just trying to think if there's anything else.
I was just thinking about in terms of how the GLP-1 medication work and when a lot of people come off them in the future.
Yeah, that's a good point to make.
So we need to go back to how the body regulates fat intake. So people might have heard of leptin, which is a hormone that's released from fat tissue. So if you've got a lot of adipose tissue, you release a lot more leptin. And it works within the feeding centre, within the hypothalamus, which is within the brain, which is exactly where GLP-1 works. Yeah. It is on that neuron, which is a GRP, a gouty or a gouty-related peptide neuron. If you inhibit this neuron, you have no desire to feed. But in studies where we've looked at rats and you stimulate it, you will just keep feeding and feeding and feeding. Yeah. So if you've got a lot of fat, leptin binds to this neuron and says, we've got enough energy in reserve, we don't need to eat. Yeah. So when we're taking GLP-1s, we are inhibiting this neuron to eat, which is why we're losing so much weight. That's why you can lose weight by basically doing what you're doing with your normal diet. But my point is, the more weight you lose, the more adipose tissue and fat that you lose, which then means we reduce the amount of leptin. Yeah. Now, if you've not changed your diet or lifestyle factors, like we've alluded to, a lot of patients don't. Yeah. When you stop this medication, you're going to have a lot less leptin that is occupying the neuron. So then your body will have this stimulus to feed to replace the energy that's lost. And then there's this idea of this set point theory, which is why a lot of people tend to go on diets, don't stick with them, because the body wants to go back to this basal level. Now, I think if you do adapt whilst you're on the GLP-1 medications, you can mitigate that risk. But until you do so, it will just be a vicious cycle. And then the only thing is, at this moment in time, you are paying a lot of money, £170 on average per month to do so.
I agree with that completely. I think, you know, we've discussed in a previous podcast that it potentially might become an issue in a couple of years' time when, you know, people start to think, oh, I can't afford this anymore, and they start to come off it. It can be like, you know, detrimental to their, not only the physical health, but also the mental health, from my opinion. Because I think, you know, if you've lost all of this weight and then all of a sudden the drug gets taken away of what was helping you, you know, keep the weight off. And like you say, you go back into old habits and, you know, this amount of leptin is massively decreased. You then get an increased desire to feed, you know, and then you've all of a sudden gone from losing the weight to putting it back on. It can be quite mentally challenging, I think. And so we do need to be thinking about that as health professionals, but also people taking the medication, that it is just so important to try and educate yourself whilst you're on it, because they really can be life-changing. You know, they're giving you a real good chance of being able to sort of reset, because I do get how it is hard to fall into habits, especially with the abundance of food that we have nowadays. You know, I understand that it is very difficult to sort of live a life where you're completely avoiding it all, because it's very hard. But you have got a chance when you're on these medications, because you do get, you know, suppression of your appetite, so you don't want these types of foods. I also read that whilst you're on GLP-1s, the types of food that you don't want is usually the bad food, so you don't crave it. It doesn't necessarily, I don't know how this works, whether this was just in studies and whether, you know, people, it was sort of a placebo effect, but there was no effect on fruits and vegetables, but the effect on sugar and fats was reduced, which obviously is a really good thing, that you're not craving the foods that really you don't want to be. But yeah, so it is a really good opportunity to reset, but it just means that you have to be mindful that, you know, unless you can remain on them forever, which at the moment we don't have studies beyond, is it 5 years, is it? Being on, oh no, it used to be a couple of years, didn't it?
Do you mean preclinical before it's into? I think I've seen 88 weeks as the maximum.
Okay.
I've seen 72 definitely, but I think 88.
But then in terms of how long were patients allowed to be on it for, it was...
I mean, there's no actual guidance on that, I don't think, at the moment. I think it's just clinical sort of opportunities.
Yeah, but it's obviously something to be mindful of anyway. But yes, is there anything else that you want to go over in terms of diets associated with GLP-1?
No, I'm happy with that.
Okay, so then the next thing that has come to our attention is this microdosing.
Yes.
I've heard it be called the golden dose. I think it may be the same thing as what you're referring to here, where, well, the golden dose is where a patient will use the last bit of the pen. So usually a pen will have 4 doses in it. And then once they've used the 4 doses, there's usually a little bit left, and then patients will use it as a 5th dose called the golden dose. Is that what you were referring to?
It isn't, but
okay.
I'll let you go on.
To be honest, I don't really know too much about it. It was just that I've seen online, especially on these TikTok groups where, people are advocating for it. Now, the issue with that is that we slowly titrate these drugs up to a dose because of the risk of side effects. So as you started this medication, the main side effects are nausea and vomiting, and it can be quite profound in quite a lot of patients. So we start off low and then gradually increase. The issue is that if you're having a golden dose, you don't actually know how much of the drug is contained within that amount of fluid. It could be a lot less than what the dose actually is or what is actually stated. And so, you may then, your body, if you give it, a golden dose, the levels are dropping below what we need to maintain a steady state of drug concentration within the blood. So, and then if you then give the dose the next time, which is obviously a higher dose, you may then get a lot of side effects. I mean, you just don't know. People react to it differently, so it's just dangerous, and we would definitely not recommend doing that.
No, I wouldn't. The microdosing that I was alluding to was actually having a dose that's less than what you should be at each time.
Okay.
So the way we go up from 2.5, 5, all the way up to 15 with Mounjaro, for example, it is doing less than what you should be at that one point. I don't know how you do that in a pre-filled pen. So I've been looking at a few blogs where they do it in America and they've been reconstituting it.
Right, okay. So taking it out of the pen or as a vial?
As a vial.
Right, okay.
Because there was a couple of blogs where it was saying in America it was $800 to $1,000 a month for a certain GLP-1. So it was $130 if you went via the vial and reconstituting it yourself. Right. Now in the UK, it's only a pre-filled pen. So I don't know how you would microdose with that, if I'm being honest. No. But it's the same thing. There is no guidance and no study data on underdosing per each interval. And if you are doing it with a vial, for example, there's that risk of not actually having the dose that you intend to have. So let's say you think not mixed properly. So let's say you should be on 5 milligrams weekly, and you say, well, I might have 3 milligrams. I'm not sure what regime they follow, by the way, but you could potentially be giving yourself a bit less than that. So your next dose could be higher. So then you could be predisposing yourself to higher amounts of side effects. Yeah. I mean, if you are lucky enough to be on this medication, I would stick to the dosing regime that's being set up by the manufacturer. That's what I would go with. Yeah, well, I was going to say, if you start to do that, it becomes an unlicensed medication then, which means that, it's not being studied, and if anything were to happen, you are not covered as an individual, because it's not within the licensing of that drug. So, it gets into quite dangerous territory, I would say. Yeah, I think a lot of people forget that. So when you use a medication out of the guidance that's being set, people think the prescribers are not covered, but also the patients aren't, especially if you're buying it over the counter or via other methods. But if you are lucky enough to be on this medication, I would just stick with the dosing regime that's set out where there's actual clinical data. And it's become more lenient now, where if you didn't tolerate the dose above, you can now stay on a lower dose. So we've allowed that. I don't know whether that's more for financial implications, but I'm not too sure. But you've got more opportunities now to still take this medication than ever before. Right. Okay. So that was interesting. I didn't actually know about that, but definitely wouldn't advocate for that. Okay. So then the next one was the MHRA warning. So the MHRA are the Medicines Health and Regulatory Authority within the UK.
Have I said that right?
Yeah.
And basically they just come out with any update on all medications. So it could be whether a medication is out of stock, or whether it could be a new side effect, or if there's any drugs that need with recalling due to manufacturing issues. So the MHRA operate in the UK. The US will probably have their own division where they send out alerts about medications. So this new one about GLP-1s was that there is an increased risk of aspiration with surgical induction. So basically just meaning that patients who have been going under anaesthetic or under any type of sedation have been, well, I think there was a few cases I read where food was contained within the stomach was then sort of regurgitating up the esophagus and into the windpipe and then into the lungs, which is then called pulmonary aspiration, which, you know, they can then develop infection, and it can be life-threatening if it's obviously not detected and not treated appropriately.
I think the risk comes about because a lot of these medications, especially in the UK, are prescribed privately.
Yeah.
And when you prescribe privately in the UK, the information will eventually come over to your GP record.
It should do if you're getting it from a reputable source.
Yeah, if you are going via online pharmacies or online GPs. But then there may be a lag in the time it comes across the documentation. Yeah. And then sometimes the GP surgery might not update it because they're not prescribing it.
Yeah.
So it might go into another section, which is what we do. We put on a hospital section for reference. So a lot of these patients might be going into surgical procedures. Do you take any medication from your GP? No.
Yeah.
They're not wrong. Mm-hmm. But then they're not saying, actually, I take this injection for weight loss, which is then leading to delayed gastric emptying, which you're saying keeps all the contents within the stomach and increases this aspiration type effect, which can lead to aspiration pneumonia, which is a hard to treat lung condition, really.
Yeah.
You're on antibiotics a lot longer than generic pneumonia.
Mm-hmm. Yeah. And I think, again, it's that thing about if you're not telling your healthcare provider, so it's usually the anaesthetist at a pre-op that you will be telling, what can they do? If they don't know the information, there's nothing that they can do because they don't foresee that. Whereas if you obviously let them know, it can be foreseen, and they can ask you to maybe fast for 24 hours rather than 12 hours before your procedure, etc. But I think they were thinking about coming out with sort of a general guidance for patients on GLP-1. So, for instance, telling them to fast for longer than the general population. However, I think at the moment it's sort of on an individual basis. So your anaesthetist or your consultants, you know, your surgeon will assess you before the operation and then, you know, put the right measures in place before the procedure. Obviously, it gets a bit tricky if you're going for an emergency operation.
It does.
But obviously that, again, is just something that we couldn't foresee, and it's a risk versus a benefit at that moment.
It is.
And so, yeah.
But this warning also highlights that any medication, whether it's herbal, vitamins, whatever, you should declare prior to going to any appointment, ideally. Yeah. But especially if you're going for a surgical intervention.
I think actually that's a good point to make, because maybe a lot of people think because it's for weight loss and they're getting it from a private company, it's not a medication that the NHS need to know about.
Yeah.
And maybe they think about it in a different way than what we do. So obviously the reason for why we need to know what medications you're on is because we need to know if there's any interactions with any of the drugs we're using in the anaesthetic, or any of the drugs we're using after you've come round, or whether, you know, it can affect the amount of time that we need to allow you to fast, or things like diabetic medications. If you're not eating, it can affect your blood sugar, so it can cause hypoglycemia. So all of these things is what we're thinking about. It's not to see, what medications you take. There's a lot more to it than that. So that is a good point, actually, the reasons for why we ask it are a lot broader than what maybe someone would think.
Yeah, and I don't think people realise how potent these medications are. Yeah. So we've got we've got the hormone naturally, as we keep mentioning in other podcasts, and it's around for 1 to 2 minutes. Yeah. We looked into it the other day, and there's a group of medications called gliptins. So you'll have linagliptin, sitagliptin, however you want to say them, DPP-4 inhibitors that they're classed as. Now, this leads to an increase in GLP-1 by 3-fold. Yeah. But these are classed as weight neutral. So if you give a diabetic patient these medications, you won't see any weight loss, and it's a negligible effect on the blood glucose, isn't it? Now, these GLP-1 medications, I've heard, increase your GLP-1 hormone by 1,000-fold. Yeah.
So that's
1,000 times more potent than your natural hormone, which just shows that these medications need to be treated with a lot of respect and care.
Yeah, definitely.
That was very serious.
No, Okay, so then we'll go on to the next risk, and that is diabetic retinopathy increases with GLP-1 in those who have established retinopathy and poor HbA1c control. So I think this is alluding to mainly patients who are taking GLP-1s for the treatment of type 2 diabetes.
Yes, but you can, as per the licensing now, be on GLP-1s for weight loss and still have type 2 diabetes.
Okay.
But yeah, this only come about, I mean, I think it's only been introduced into the manufacturer's leaflet recently.
Okay.
Because it was found in a few previous studies that there was no significant increase in diabetic retinopathy. Now, retinopathy is basically eye disorders that can eventually lead to blindness.
Yeah.
And I think diabetic retinopathy accounts for about 7%, if that's a figure I've remembered from previous podcasts.
I think it's the leading cause of blindness, isn't it? In the, I'm pretty sure it is.
I'm not too sure. 7% sticks in my brain for some reason.
Okay.
But either way, it's a highly preventable cause of blindness.
Yeah.
And it was found non-significantly before to having a sort of an association between them.
Yeah.
But now recent studies, I think there was one called Sustain 6, and that did show an increase over placebo. And I think in the treatment group, which were given Mounjaro, I think had 50 cases versus 29 in the placebo group.
Okay.
So it was significant.
Yeah, so that is significant. Yeah, so diabetic retinopathy is a risk of people who have poorly controlled diabetes anyway. But I mean, it could be the fact that, again, more and more people are using these drugs. So I know that was in a group of people that they were testing.
Yeah.
But we possibly could see more just due to the amount of people that are taking it. Do you know what I mean?
Yeah, I mean, there's one thing I actually don't know. So it said the risk increases in those who've got poorly controlled HbA1c, which is your diabetic blood long term, and a history of diabetes in general. Mm-hmm. And the mechanism it was suggesting was a quick reduction in blood sugars was leading to increased retinopathy. It was the rate at which they were being decreased. Okay. I couldn't see anything else other than that. I tried to look into other studies.
Okay, that'd be interesting to find out why that would be, but that's really interesting.
It was the rapid reduction is what they stated on there, which is counterintuitive,
yeah, you would think so. That's interesting. That's probably something that we could look into. A really good point. But yeah, so just again, something to be aware of. Then the next one is pancreatitis. So this is a well-established, well-documented risk or side effect of GLP-1s. Uncommon, but still a risk. And also, patients who have had pancreatitis, especially whilst on these medications, then it's sort of a contraindication really to then ever be put back on one. The drug has to be discontinued, and you will usually need an admission to hospital to be treated for it. So pancreatitis is just inflammation of your pancreas, and you will usually know about it because it's meant to be a very, very severe sharp pain right in the middle of your sternum, and it usually goes right through to your back. I actually was looking the other day, and it was ranking pain from like the worst ever pain to to things like, I think one of them was like sciatica. So I think that was ranked actually in the middle.
And where was a man being kicked?
I actually didn't see that, but pancreatitis was up there. It was quite high. I think it was like third. So I think kidney stones was the top, which I have heard. Then childbirth was second, and I'm pretty sure pancreatitis was third. And this was out of about.
And where was the one that I was saying? Where was that listed?
I didn't see that one.
Because that must be up there, highly, because you never get asked. You never ask another man to kick you in that same area, but then a woman will go through childbirth at least once.
Yeah. No, I think
it's got to be worse.
I don't think that was on there, but no, the point was that it was quite high up pancreatitis. So yeah, it is a very severe pain, apparently. And like I say, yeah, you would need to be treated for that.
It's a medical emergency, so you must seek attention at that point. Stop taking the medication that's induced it, in this case a GLP-1, and then, like you said before, you will not be able to go back on this medication because there's a high link that it will happen again.
Okay, so then the final one that we wanted to talk about was fertility and planning pregnancy, which I think is an important one, because if you think about the cohort of patients who are on this.
Do you know what percentage were females who take GLP-1s? This was last year, by the way.
Was it? Okay, I'm going to say about 70%.
No, a bit less, just under 60%.
Oh, was it? Okay.
But it is disproportionately women. And a lot of younger women now are taking it because of the social media industry and all aesthetics driving all these unrealistic body images. Mm-hmm. But I think fertility is one thing that is hard to study in a short period of time, and it happens later on, doesn't it? It's all retrospective. At the moment, there are no studies or data on whether it does affect your fertility. From what I've seen, I don't think it affects any animal models from what we've done, but that doesn't mean it doesn't affect humans.
I mean, it's a really interesting point, because I personally, from my practice, have heard of, or I've had a lot of letters through from fertility clinics putting patients on these medications to allow them to lose weight, because we know that obesity is actually it reduces your risk of getting pregnant. So they're giving these patients medications to reduce the weight to help them to get pregnant. And also patients who are going through IVF, they're not eligible for, well, in certain parts of the country, for IVF above a certain BMI. So again, these clinics are suggesting that they go on
I thought you were going to say that.
Yeah.
And then also, if you are pregnant, we'll get on to whether you should take these or not for weight loss. But if you are pregnant with a higher BMI above 30, you are increasing the risk of neural tube defects for your baby. So that's why we put you on higher doses of folic acid. That's on one of the criteria from the midwife.
But obviously you would only be on it for type 2 diabetes or the treatment of it. Would they switch you though? Would they switch you to metformin and insulin? Or
if you are pregnant, again, there's no data because we can't study medication ethically within pregnant women. Animal studies show no effects. For weight loss, there's nothing on there. It's a risk versus benefit.
Yeah.
So for weight loss, I personally would say...
Well, you wouldn't want to lose weight, surely. I mean, I know that.
You're going to be gaining weight through pregnancy, so it just seems counterproductive. But in terms of vanity, I think you should not be on it for weight loss if you're pregnant. Remove that risk. If it's for diabetes, it then will be weighed up with your consultants, because if your diabetes control is poor and the risk of that going out of control outweighs the risk of being on it with pregnancy, then you would stay on it. But in terms of data, animal studies don't say anything bad about it, but we don't have anything in humans.
Well, yeah, but I think we sort of have to look back at like the thalidomide issue, don't we, where it come about that was okay within pregnant women and was actually used for morning sickness.
It was, but that was a very, very unfortunate scientific...
It was, yeah. But my point is that you have to be mindful about these things, even though it says, it's safe. If you're using it for something like weight loss, then, I just personally would think that it wouldn't be worth the risk,
I don't think so.
That's what, obviously, unless it was, again, a risk versus benefit and you would weigh it up and it was this, I am this overweight that it's really detrimental to my health and my unborn child's health. But, if it's just purely for losing a couple of pounds, then it just is not worth it.
I think the only way you stay on that medication is if your diabetic control, if not treated in the short term, leads to kidney damage, potential blindness. Yeah. I think that's the only way you stay on it. I don't think any other clinical reason you stay on it.
But again, obviously, this would be a decision that would be made between the patient and again, it's all about, we're just trying to educate patients on what are the risks, are there any risks, and what would we do in that situation, just so that patients have a better understanding of things.
Yeah, we've just been stopped on this medication because of this, because there's all these risks.
Yeah, and at the end of the day, within healthcare now, we are in an era where patients are taking more accountability for their own health, and the way that you can do that better or to a higher degree is by education. So if you understand how it works, what the risks are, if you are willing to accept those risks and you've discussed it with your consultant, then I'm pretty sure that they're always going to make a decision with the patient, because that's what we are told to do now, is more patient-centered care. And like I say, with this particular medication, it hasn't been shown to cause any issues in terms of fertility right now. There is an increased risk of neural tube defects, which there are with quite a lot of medications. But, if the benefit of being on that medication is greater than the risk, then we would just give a high dose folic acid, like you say. So,
do you mean with increased weight, the neural tube defects?
Oh, is it? Oh, sorry, I thought you meant with the actual medication.
No, I mean, that's why... if you reduce your weight, that's what I meant before. We haven't got any data really on GLP-1. Same with breastfeeding. So if you've been lucky enough to give birth, should you be on a GLP-1 with breastfeeding? Again, there's no evidence that it's secreted within breast milk. You would only be on it again, in my opinion, for poorly controlled diabetes at that point. That is of threat to your life. So for weight loss, you wouldn't be starting it straight after being just giving birth, would you? You would be waiting at least 6 months.
Yeah.
And then the last one is, what happens if you are becoming or planning on becoming pregnant? So these medications now, we are able to dose it over a week. meaning that, what's it, 5 half-lives, isn't it?
Yeah.
To give or take, remove it from the body. So 5 days, I've heard, is the half-life of Mounjaro, give or
I've
take.
heard that.
So 25 to 30 days, the drug should be completely out your system. So if you are planning on becoming pregnant, you would be liaising with the prescriber who's giving you the medication. But ideally, they should be telling you to stop it at least 1 month before you plan to conceive. And then when you are taking the medication and you are sexually active, you should ideally be on some form of contraception, because we know there's unplanned pregnancies, and then you want to reduce that risk as much as possible. But I think the whole thing around it is, if you are taking it for anything other than poorly controlled diabetes around a pregnancy discussion, I don't think it's clinically relevant.
Yeah. So I think that's all the things that we wanted to discuss, unless there's anything else that you want to touch upon.
No, they're the risks that we've went through for now. I'm sure there'll be more coming out, because the more and more people that take, you will find it in the population, because there's so many genetic polymorphisms.
Yeah.
People take it in different ways. Microdosing now, that's going to lead to more complications. The golden dose.
Yeah.
So we need to keep an eye on these things, and they're not going to be going away anytime soon. The market cap for these medications, like you said, are growing and growing. It was how many billion before, you said?
£126 billion it'll be worth, the GLP-1.
In 4 years.
Yeah. Yeah, it's a lot of money.
They're not going around for any time soon. And because there's no evidence of the ability to keep your weight off once you stop them, I think a lot of people will be coming off, going back on, and it'll just be the new dieting, but at a big expense.
I was actually thinking about this the other day in terms of, I think if we look back in history where we have sort of like eras, so like we had the COVID-19 era, I think this is going to be known as like the GLP-1 era, because it's such a huge topic. You hear it all of the time on the media. Any conversation that I have anyway with being a pharmacist, it's always about these medications. Are they good? Everyone wants to know. Everyone's fascinated by them. And like you say, they're not going to be going anywhere away soon. They are very effective medications, but at the end of the day, they are medications, and a risk benefit needs to be had between yourself and the prescriber before you decide to go on not just this medication, but any medication. But yeah, so thank you so much to everyone for listening. If you've got this far, if you haven't already, then please like and subscribe. And also, this is for informational purposes only and should not be used in substitution from seeking advice from a healthcare professional. And we'll catch you at the next one.